so go ahead and get started. I'm Hannah Norton. I'm a reference and liaison librarian at the Health Science Center Library, and we're happy to have you here for part of our series of talks on HIV and AIDS, accompanying the National Library of Medicine exhibit, Surviving and Thriving, AIDS, Politics, and Culture. So if you haven't seen it already, it's not huge. Just pop over into the library right across the hall and take a look at the exhibit. It is very interesting, and they have additional materials online as well. I also want to thank we have some funding for our U.S. Center for the Humanities and the Public Sphere with support from ULI funds, so thanks to them for funding. There are a couple handouts towards the back corner there. If you don't already have one, please do grab an evaluation form. This is mostly just to let us know how you find out about our events and if there are other kinds of events you'd like the library to host. You can just drop that off at the end of one of the aisles at the end. We also have a little flyer that tells you about upcoming events in this series. So do grab that. The next event is next Thursday. We're screening the movie Dallas Buyers Club that evening. And I think you probably were caught on your way in, but also please do sign in just by printing your name. We're not going to contact you in any way because of that. That's based on the funding that we've gotten. But we need to collect names for when food is distributed. So with that, I want to welcome you to this talk by Dr. Susan Ball. She's the Assistant Director of the Burn-Bound Unit at the Center for Special Studies at the New York Presbyterian Hospital and Associate Professor of Clinical Medicine at Weill Cornell Medical College. She's worked as a clinician caring for patients with HIV and AIDS for over 20 years and is author of the book Voices in the Band, A Doctor, Her Patients, and How the Outlook on AIDS Care Changed from Doomed to Hopeful, which was published this last year. We do have an ebook of that in our collection, so check it out. And with that, I'll hand it over to Dr. Ball.
Thank you, Hannah. Can everyone hear me? Not too loud, not too soft. Thank you very much. Thanks so much for inviting me to come here today to Florida. I flew down last night from New York. And the title of my talk is Early Years of HIV, and I'm going to really talk about HIV in the 80s and 90s. As Hannah said, I've been an HIV care provider for patients with HIV in New York for going on 25 years now. And as I'm sure you're all aware, there's some very big changes that have happened since the advent of this epidemic in the early 80s. And particularly in the 90s, it was a really transformative time. I started working at the Center for Special Studies in 1992, when really we had no effective therapy to treat our patients who were progressing to immune suppression and death in very rapid numbers, which I'm going to talk about. And then there was this real transition time when effective medicine came along, and I work in a dedicated HIV care center where we provide a multidisciplinary approach. So we have nurses and social workers, we have full-time nutritionists, we have full-time psychiatry, GYN. We now even have dental care. So we have a real team approach, and that has really helped us all and sustained us all during that, particularly those dark times in the late 80s and early 90s. And in my own experiences of this and seeing this transformation through the 90s, I started to write a book about it, about my own experiences and the experiences of the team and some of our patients. And I got about halfway done, I thought, in about 2006 or so. I was about halfway done with my book, and I showed it to a friend of a friend who was in publishing, just to get her sense of it. And she basically said, don't quit your day job because your writing is pretty bad. But she also said, excuse me, she said, why are you writing about these people? Nobody cares about them. And for me, that was very discouraging, and I kind of put the book away for a couple of years. And then in 2009, the Narrative Medicine Masters of Science degree program opened at Columbia University. And I thought that was very interesting. And it was run by a woman named Rita Sharon, whose name some of you may recognize. She's been very instrumental in the narrative medicine field. And for me, what that meant was, what is narrative medicine is the question that people ask a lot. And because now I have a Master's of Science in Narrative Medicine. narrative medicine involves listening and connecting with the stories, patient stories of illness. And it has to do with, in my own interest in it, it has to do with where medicine has gone and shifted so far into the technology and what we know about what we can do with imagery, what we can do with technology, what we have are constraints on time, issues of litigation, quality assurance, administrative responsibilities. Less and less time is spent really face-to-face with the patients. Narrative medicine allows a real connection with the stories of illness, both understanding the patient's illness as a part of their larger life narrative, but our own stories and what we are bringing to our patients. Who I am as a woman, as living in the Northeast, speaking French, liking to ski, all these things I bring to my patient encounters. And then we have a patient encounter, Dr. Ball taking care of her patient with Pneumocystis pneumonia, and that becomes a story. And so recognizing those stories, I think, allows us to connect better with our patients, and ultimately I really think it helps provide better patient care. So I give that as a bit of a prelude, because part of this talk I'm going to punctuate with some readings from this book that I wrote that was published by the Cornell University Press last March. I'm glad to hear it's available and would be thrilled if any and all of you would read it. It's available on Amazon as well. But I'm going to just kind of refer to the book in a couple of times in the talk just to give sort of a background and maybe an anchor for some of this talk. And this talk itself is really sort of a narrative, and it's a sort of a story. Looking around the room, I think there are some of you who remember those very dark days of HIV, in the early days of the epidemic, and there are probably others in the room who, when it was going on, perhaps you were but a twinkle in your parents' eyes. So it does have, it's a finite thing in that the first AIDS cases were recognized in the early 80s. And here we are now, 2016, and we're talking about potentially curing HIV. We don't have a cure for it. It's really not a curable illness at this point, but as many of you know, we've rendered it really an illness that we can treat very effectively and have it be a chronic illness, something like diabetes or high blood pressure, something you can't ignore, but something you can really treat and have people have a long and healthy life. But we learned so much from HIV and AIDS in those early years, and a lot of the missteps and things that went on in the 80s and 90s. So much progress was made in virology and immunology and epidemiology. And so here's some examples of more recent virally mediated infections. All of these are vector-borne, so they're not entirely in the same class as HIV, but all of the things that we've learned from HIV have informed our response to and our ability to deal with these infections. Zika, for all of us, is kind of coming this summer with the Olympics in Brazil, and here it is in Florida this summer, and in New York. I think people are very concerned of how much Zika are we going to see around in this summer. But these all our knowledge of and response to these infections has been informed by all the lessons and knowledge that we learned from HIV and AIDS. These are just some other photos of that. I just wanted to show this lower map is the Zika risk map for the U.S. And you see the dark red area where they think most of the Zika, the highest prevalence of Zika cases in the country will be. But, a lot, Florida obviously is going to have a lot, and New York is anticipated to have a lot, and scattering throughout the country. So these two articles really are traced as the earliest cases of acknowledged cases of what was not even then known as HIV, but these were the first cases that we look back and recognize this was when it started. The MMWR report from June of 1981. This is a small cohort of gay men who had Pneumocystis pneumonia who were collected in Los Angeles. And what's interesting, and again, to put it sort of in context, is realizing that HIV is an immune suppressive disease. So patients who have profound immune suppression can present with such a variety of problems. Virtually any organ can be impacted.
So patients could present to their psychiatrist with AIDS mania. They could have dermatologic issues. They could have pulmonary or GI or ENT or oral ulcers or Kaposi sarcoma. So when you think about it, patients probably throughout the 70s were presenting in isolated cases, probably in urban areas where there were higher concentrations of gay men and drug-using people. So that if you looked back through charts, and you would probably find a case of CMV retinitis here, and a case of cryptosporidial diarrhea over there. But it wasn't until there were more and more and more that suddenly somebody said, oh my gosh, we have 5 cases of pneumocystis. Pneumocystis hadn't been really recognized since the 1950s in Turkey in a orphanage where people were very malnourished. So this was the first documented cohort, but by this point you can really understand that HIV was really throughout the country, and again, particularly in the larger urban areas where there were more gay men concentrated. By the end of 1981, 270 documented cases of this severe immune deficiency. Didn't really have a name yet. 121 of those people had died. And again, some of the first cases, because they didn't know what to call it, and it did seem to be associated with homosexuality. Some people called it GRID, or gay-related immune deficiency. Some of you may remember that acronym. In 1982, I'm going to show you a few slides with these sort of timelines of just things that happened. So in 1982, the first clinic opened in San Francisco. The Gay Men's Health Crisis, which is a very, very large project in New York, which supports gay men and has medical facilities, but also lawyers and support groups and helping people with social services. That was started also in 82. There was a congressional hearing to designate some funds. There were the first infants diagnosed. So this wasn't suddenly, oh, it's not just a gay-related immune deficiency, but here are some babies. And the acquired immune deficiency syndrome was used by the CDC for the first time in 1982. 771 cases and already 600 deaths. Now, I bring this slide because the response on the top levels of the government were definitely not what would have happened probably today. Homophobia is something that, obviously here in Florida right now, is something that is unfortunately too alive and well all over the country. But in the early 80s, it was another, I don't know what you call it, another ball game. So this was an interaction between the press secretary, who was Larry Speakes under Ronald Reagan, in 1982. I'm just going to read it. Larry, does the president have any reaction to the announcement the Centers for Disease Control in Atlanta that AIDS is now an epidemic, have over 600 cases? Mr. Speakes said, what's AIDS? The questioner says, over a third of them have died. It's known as gay plague. To laughter in the room. No, it is. I mean, it's a pretty serious thing that 1 in every 3 people that get this have died. And I wondered if the president is aware of it. Mr. Speakes said, I don't have it. Do you? To laughter. No, I don't. Mr. Speakes said, you didn't answer my question. Questioner said, well, I just wondered, does the president? Mr. Speakes says, how do you know? Again, to laughter. So the questioner says, in other words, the White House looks on this as a great joke. Mr. Speakes said, no, I don't know anything about it, Lester. And it's hard to imagine these days that conversation could possibly take place. Not only from the homophobia that's reflected in that conversation, but also thinking that already 600 Americans had died of an illness. And we think about SARS or Ebola or the H1N1, 2 or 3 people infected, and everything was mobilized, everything up in arms. And so those epidemics have not taken place. And I bring this point in that had there been more direct emphasis on controlling this virus and on really identifying it and identifying those involved, would the epidemic have unfolded in our country the way it did? I don't think there's any way to know, obviously, but I think the question is important to be raised. By 1983, We began to call it the 4-H Club because it was recognized that homosexuals, hemophiliacs, heroin addicts, and for some reason Haitians were people that were felt to be at high risk for having HIV, they weren't calling it HIV yet, but calling it this immune deficiency. Luc Montagnier in Paris identified a virus that he called the lymphadenopathy-associated virus, and it was linked to this illness. And the CDC put out a statement noting that this was not something carried in the air or in the water. This wasn't something that you got from riding on the bus with somebody. That there was really this knowledge and sense that this was transmitted through blood or body fluids. Another congressional committee noted that the funding was not good enough. 1983, 2 years into the epidemic, 2,800 cases, 2,100 deaths. In 1984, Bob Gallo at the National Cancer Institute, which was sort of a precursor to the National Institute of Health, he identified a virus which he called HTLV3, and Jay Levy in California identified a similar virus, and ultimately Montagnier and Gallo and Levy got together and recognized that their virus was really the same virus that they're all talking about, and it was called human immunodeficiency virus, or HIV, which has been called ever since. By 1985, a blood test was licensed to be able to identify people who had been infected, and the CDC issued some guidelines to know what is the definition of AIDS. In that year, Hudson died from AIDS, and this was a big piece of news because it really brought out almost an iconic male actor who was now not only outed for being gay, but also dying from this illness. And it really, I think, really put HIV and AIDS on the front page in a way that it hadn't been so much before. Ryan White was a young man who was refused admission to school because he had AIDS. And then military recruits were denied acceptance into the military if they were HIV positive. And a lot of press has been, I almost took this slide out, but you know, a lot of people have said, oh, Ronald Reagan never mentioned HIV for 7 years, and that's sort of the legend. But in fact, he did mention it. It took a while, but he did actually mention AIDS in response to a reporter's question in September of 1985, and did actually mention it in a speech of his own in February 1986. But, you know, politicians, Ronald Reagan didn't have the monopoly on this. Later on, anything important in the paper, dear? And this was at a point later on, 250,000 diagnosed with AIDS in the U.S. He says, nope. So this is just the first 5 years of the epidemic. You see this, you know, this upward slope where the deaths are almost as great as those diagnosed. So this was a very, very bad diagnosis for someone to have. It was, people felt like it was really getting a death sentence if they got a diagnosis of HIV. And so a lot of people didn't even want to get tested because we had no treatment. There was tremendous stigma and prejudice against people with HIV and AIDS, and so many people were dying. I wanted to just read from my book, just the beginning for me, what that time, those early days were like. The first time I heard about HIV, it was called by another name. None of us could appreciate that when we were hearing about an illness whose initial impact would be like the earliest shivers and creaks of an earthquake that would shake the entire world. In the summer of 1982, after my first year of medical school, I met some friends for lunch at my roommate's house in Philadelphia. One of the people there was a fourth-year medical student at a big hospital in New York City. He told us of an illness occurring in gay men that made them very sick and sometimes killed them. No one knew what it was or what caused it. He mentioned that people used the term GRID, which stood for gay-related immune deficiency. The student said that more and more cases of this strange but terrible illness were showing up in other hospitals in New York, and that cases were now being reported in other cities around the country. We talked that day of how or why gay men would be victims of a disease like this. From the student's description, it sounded scary and ominous. Within the next 2 years, I'd seen several cases of this illness on my ward rotations. The patients were all young people in their 20s and 30s, and they were desperately sick. Some had terrible pneumonia caused by Pneumocystis, an organism that had only rarely been seen before. Some patients were covered with purple spots and carried the diagnosis of a sarcoma that was supposed to affect only old men in Greece. Others were just skin and bones, unable to eat, or feverish for reasons that we could not figure out. Gay men made up the majority of our patients, with others being intravenous drug users, both male and female, and the sexual partners of those drug users. In recognition of this broader patient population, the name for the illness became acquired immune deficiency syndrome, or AIDS. At about this time in 1984, I heard a lecture by an infectious diseases specialist at the University of Vermont. He spoke of an illness affecting large portions of communities in Central Africa, in Uganda, and the Democratic Republic of the Congo, known then as Zaire. It was recognized in Africa as slim disease because patients had severe unremitting diarrhea and could not eat. They became profoundly wasted, and after months of sickness, they died. A high prevalence of tuberculosis in these regions complicated and generally worsened the course of this illness, which predominantly affected young adults and working-age people. Because the ill could not work and required someone to care for them, economic downturns were becoming apparent in these already impoverished regions. The infectious diseases specialist giving the talk noted the link between slim disease and the acquired immune deficiency syndrome, formerly GRID, now being seen in the United States. Research indicated that AIDS and slim disease were manifestations of the same condition. Increasing numbers of cases were being diagnosed in the U.S., such that by the end of 1984, over 7,000 Americans had died of or were suffering from AIDS. Before 1981, while I was in college, this illness didn't even exist. Yet by the time I finished medical school and began my training in internal medicine, AIDS patients made up the bulk of cases in many inpatient medical hospital units. The stigma around the disease spread even faster than the disease itself, especially in those early years when the cause was unknown and the effect always devastating. The unknown frightened people. In hospitals, housekeeping services didn't want to clean the rooms of those patients. Wary food service employees left meal trays outside the hospital room doors of patients who were too ill to sit up, much less get out of their beds and walk across the room to the door. Once during residency, I mentioned AIDS to a colleague as we took the elevator upstairs. The man standing next to me jumped away from me. He looked aghast, as if just hearing the word AIDS might be contagious. So I put in this slide to just say what was going on in 1985. For those of you who are here, some of you might remember that Mel Gibson was designated the sexiest man alive. The Chevrolet Cavalier was the highest selling car in 1985. The average price for bread was 74 cents. The stamp was 22 cents, and a gallon of gas was $1.24. I don't know why I picked San Francisco, but San Francisco won the Super Bowl against Miami. I didn't pick San Francisco, I picked the Super Bowl. I could have picked other sports, I guess. But that's Joe Montana. And it was super cold that winter. Ronald Reagan's inaugural parade was canceled because it was minus 10 degrees in Washington. This was the highest selling song in 1985. Right, go from there. So in 1986, C. Everett Koop published, he was the Surgeon General, and he put out a 7-page brochure that he sent to 107 million Americans that talked about HIV and AIDS. And this was a really momentous event, really. C. Everett Koop was largely felt to have been an appointee by Ronald Reagan to appease the right. C. Everett Koop was a pediatric surgeon in Philadelphia, staunch anti-abortionist, and people felt that he was going to be, he's a very conservative guy. But C. Everett Koop was not involved in any of the early work on HIV and AIDS, and when he was finally allowed to or got involved with putting out this brochure, he went right to the heart of it. He went right to the way it was transmitted, to the way one could protect himself against getting it, and people were shocked at how overt and clear and somewhat graphic some of his descriptions were. He talked about anal sex, he talked about condoms. The right was just completely up in arms that such things would be mentioned in a brochure going out to American households. But I think this guy probably saved a lot of lives, because these brochures went out to places where people didn't have a lot of access to a lot of more specific knowledge and information. So, information is power, and giving people the education was really very, very important. And he advocated for sex education at very young ages, something else that people were aghast at. But this was a very powerful document that came out. This book, And the Band Played On, which, my book takes definite homage to this book. If you have never read it or you're interested in this period of time, it's a fantastic book. It's very easy to read. Randy Schultz was a journalist, so it reads very easily, kind of like reading a newspaper. And he covers these early days of HIV, from the science aspect to the politics to what was going on in the street, in the West Village and in the Castro, among the hemophiliacs, among the scientists. It's a wonderful book if you're interested in this topic. And just to say, excuse me, another word about Ryan White. He was diagnosed in 1984 and given 6 months to live. He was a young man who was a hemophiliac, and before the virus was identified and the blood treated in 1985, a whole generation almost of young hemophiliacs were infected because the blood supply was tainted. And Ryan White lived in Indiana, and they didn't want him to go to school because he was diagnosed with AIDS, and they thought that he would give the other kids AIDS by being at school with them. This went up to the State Court of Appeals, which finally reversed it and did allow him to go to school. But in that process, he got a lot of notoriety, and he was championed by a number of really famous people and some politicians and athletes. Elton John, Michael Jackson really were, big advocates and supported Ryan White. He was, very brave, but just, he just wanted to live his life. He just wanted to do his thing, and he knew he wasn't going to give AIDS to anybody by sitting next to them in a classroom. And it is in his name that the Ryan White Care Act was passed in 1990, which continues to provide support and funding for AIDS treatment programs around the country, and has really saved many, many lives because of it. In 1987, the first drug was approved for treatment of HIV, and this was AZT, which I'm sure you've all heard of, was azidothiamidine, or retrovir, or zidovudine. And AZT was a drug that was hauled off the shelf along with many, many other drugs in the 80s and in the 80s to try and find something that would halt the replication cycle of the virus. So AZT was the first one that was approved. It was approved because in studies, those patients who were taking AZT had their T cells, or the marker of immune health, their T cells went up, which was a good thing. And those who were not on AZT, their T cells did not go up. So in the time that the studies were done, people felt, oh, everybody who's on AZT, their T cells go up, everybody should be on AZT. So the drug was approved. There was some backlash. Not everybody agreed with this. Some people thought the studies were not done thoroughly enough. Some thought it was just a ploy by drug companies to make money off dying people. This drug had a lot of side effects, and it didn't take long to realize that AZT given alone, given as monotherapy, it didn't work very well. And we know that now, that really to treat HIV, you really need a number of pills at the same time, a cocktail, if you will, and that treating HIV with monotherapy only really results in resistance. So patients who got on the drug, many of them did transiently have an improvement in their T cell counts, but for most of them that was short-lived. So it got a bad rap, but at the same time, here was finally something, and was the beginning of more drugs being developed. So by 1990, over 160,000 cases of HIV, more than 120,000 deaths in the U.S. This is just in the U.S. Tom Cruise, sexiest man alive. Kevin Costner won the Academy Award for his movie Dances with Wolves. Joe Montana, still the quarterback, who won another Super Bowl, and the Honda Accord was the car of the year. And here's the This is the song of the 90s. Anybody know the group? Wilson Phillips. All right, you get the prize. All right. So within 10 years, this virus, you see this graph, this upward curve with really no end in sight. By 1990, over 150,000 cases, over 120,000 deaths. 1993 did show the results of the 076 study, the first really actual really positive results showing that AZT used in pregnancy significantly reduced the risk of a fetus being born, of a baby being born to an HIV-infected mother. The rates were reduced by more than 66%. And this was finally something that really had some impact on our care decisions. The movie Philadelphia came out. There had been some prior movies that were not maybe as famous, but this with Tom Hanks and Denzel Washington. Tom Hanks won an Oscar for his performance in Philadelphia. And if any of you remember the story, it was Tom Hanks was a lawyer in a really high-powered law firm in Philadelphia. Jason Robards was his boss and discovered that he had AIDS and fired him. And Denzel Washington was his lawyer. It's a great movie if you're interested. This is just some pictures of people, some of whom you may know or recognize, and most of them are dead. A couple important ones are not dead. Magic Johnson is still alive. He came forth with his diagnosis in 1993, and this too was really, along with Rock Hudson and maybe all these others, but Magic Johnson, the picture of health and his beaming smile and his athleticism. He went public with his diagnosis, and this was really important for young people, for kids, and for just to take a little bit of the stigma away from it. To say, here's a guy's, he's infected, and but it's not the end of the world, and people need to acknowledge that people have this illness. I'm going to read you another section of a patient of mine who I took care of, who was in our clinic, just to talk about for us this time in, again, the early 90s, and with that curve of so many patients coming in being so sick. Sabitha had a smile that rivaled that of my old patient Mac. You just couldn't help but smile back. When she first came to the hospital with PCP in 1994, she did not look like a 24-year-old mother of four. She looked like a nubile young teenager, lustrous hair set off dimples and sparkling dark eyes. Her dead ex-boyfriend, the father of the three younger kids, had never told her about his AIDS diagnosis. Miraculously, none of the kids carried the virus. Sabitha seemed strangely apathetic when I talked with her of that diagnosis of PCP, which meant she had AIDS, as if the information had stopped on the doorstep of her brain, but not entered. I tried to imagine what she must be feeling. Dead boyfriend, 4 children, AIDS. Who could imagine being in that life? I stood in the hospital room with her, trying to figure out why she was talking so oddly, and why her muscles seemed to be losing their strength. Admitted from home after 2 months of progressive weakness, she had muscle spasticity and her legs would not hold her up. She could move them and could move her arms as well, but her muscles jerked uncontrollably at times, and she spilled her food when she tried to eat. She complained that her left leg felt numb and that her hands would jerk suddenly on their own. She'd also had a gradual change in her voice that caused her to speak in a nasal, halting way. When I asked her why she hadn't called me when this started 2 months ago, she told me that she'd been frightened. She didn't want to get bad news. Her fears were justified. Things did not look good. The neurologists shook their heads and shrugged their shoulders. We waited to see the brain images from the CT scan. In the area of the cerebrum where the scan should be gray and uniformly colored, we saw instead a lot of large, white, cotton ball-type abnormalities. The brain itself was smaller than it should be for a woman her age. On scan, Sabitha's brain looked like a big old shriveled prune. So now Sabitha, at 25 years old, had what radiographically looked like the brain of a 90-year-old. Her appearance had changed markedly as well. Coarse, lumpy skin and dull, dry hair took the place of her previously dewy complexion and thick, shining mane. All the muscle twitches and spasticity in the abnormal CT scan led us to give her a diagnosis of AIDS encephalopathy, or possibly something called progressive multifocal leukoencephalopathy, or PML. Both resulted from advanced immune suppression and affected the central nervous system. A biopsy might differentiate between the two, but it didn't matter which of these she had, as no treatment existed for either one. The likelihood of recovery seemed all but non-existent, and although she took 2 drugs for her HIV, her T cells remained very low. We talked to her about going to a nursing home, but she insisted on going home to be with her children. I knew that her going home could not last long. Soon Sabitha would need more care than we could provide for her as an outpatient. And she did, in fact, come back. She went home, and a few weeks later came back and needed to go to a nursing home. And that happened more times than I would like to remember, sending young people to a nursing home, really where you thought they were going to die, and most of them did die. We did have, as I mentioned, Sabitha had 2 medicines. More drugs were being developed. These were all in the nucleoside reverse transcriptase family, so they all attack the virus in the same place in the replication cycle. AZT in 1987, and we had didanosine, and then we had DDC and D4T and 3TC, and we learned that patients did a little bit better if they took more than one at once, and so this notion of resistance, viral resistance, became something that we were aware of, although in this time, the late 80s, early 90s, we weren't able to measure the actual virus levels. We could only measure the T cells, which was sort of a surrogate marker of what was going on in terms of the virus. But by the mid-90s, we could actually measure virus levels. We called that the viral load. But in 1994, AIDS became the leading cause of death for all Americans aged 25 to 44. And it was the peak number of deaths occurred in 1995 when more than 50,000 people died just in this country. This is a picture you may have seen. I think it was in Time magazine, just a picture of what this disease did to individuals, but also did to families. And I'm going to read another section from my book about a patient of mine who I cared for. I knocked on the door, and Marco's mother said, "Come in." The window in the room looked out over an interior courtyard. Most of the room was in shadow, but for a dim light over the empty hospital bed. Marco's mother sat in the half-lit space near the window. "Hello, Mrs. Prava." "Hello, Dr. Ball." She always greeted me in a way that seemed quite formal, but over the last few weeks I had come to know her as warm and articulate. "Where's Marco?" "He's gone to have an X-ray." "Has he been gone a long time?" "Not that long, maybe 20 minutes. "You're sitting here in the dark." "Yes, I'm waiting for him to come back." "How is he today?" I went closer and sat on the ledge of the window facing her. "He's about the same, very weak, very weak." I sat looking at her in the gloomy room. The vaguely foul odor of disinfectant over feces wafted about us. There had been times when this room defied the strongest stomach because of the smell. Today wasn't bad. Cryptosporidium, the infection in Marco's colon, caused a constant watery diarrhea. Day and night it had slowly sapped all his strength, all his fat, all his muscle mass. No known effective cure existed for cryptosporidium, and it seemed that nothing we gave him helped the diarrhea. Marco's body epitomized the expression skin and bones. On the bedside table stood a photograph of Marco and his mother in another time and place. They smiled together, looking at the camera while palm trees waved in the background. The tall, handsome man in the photograph had brown eyes and broad shoulders, and looked nothing like the Marco I saw suffering and wasting away each day in this miserable hospital bed. Soon we'd be deciding whether Marco should go home in his mother's care or to a nursing home. Although I'd discussed the options with both of them a couple of times, they were not considering anything other than Marco going home with his mother. I wanted to offer another alternative. Having him at home was going to be a tremendous strain on them both. We could help by setting up nursing services and a home attendant for support with changing beds and doing laundry. But Marco needed constant care, and he and I both worried about how this would affect his mother. I looked at Marco's empty bed with its clean sheets stretched tightly across and the knitted blue blanket from home folded at the foot. "Mrs. Prava, how are you doing?" "I'm all right," she said. "Are you getting enough rest?" "I get home late, but I guess I do, yes." Marco told you to stop sleeping here, didn't he?" Marco was worried about me. She gave a little chuckle, looking at the floor. Marco worrying about his mama. I waited for her to say more. She lifted her head and looked right at me. "He has the AIDS, doesn't he?" Her question surprised me. I had assumed that she knew, but in fact, I had never actually spoken to her about it. The diarrhea came from an infection that we spoke of very freely, but AIDS had opened the door for that infection. We had never overtly discussed the underlying cause. Too many assumptions. I felt my face turn red. "Mrs. Prava, I have known for a long time. You don't need to worry about telling me. Marco did not want me to worry. He wants to protect me." She was looking past me, talking more to herself. "I have known for a long time that Marco has the AIDS. He might even think now that I don't know. We don't talk about it anymore. We're just trying to care for him, to get him to eat a little bit. The diarrhea, it's so strong." Before, when he was better, he had a friend who came to our house a lot. A beautiful young man, so handsome and so funny. Always sweet to me and a good friend for Marco. And then he was not coming to our house so much, and when he came, I asked Marco, "What is wrong with Eric? He is so thin and his pants are falling down from his hips." Marco said he didn't know. And then Eric came one last time and he was coughing and sweating, and he cried when he said goodbye. I said to Marco, "This boy has the AIDS and he is dying." And Marco said, "No, Mommy, he's just sick. He's okay. He'll get better, don't worry." But I knew that that boy was sick with the AIDS. And then Marco started to not eat well, and he was swimming in his shirts and wearing his belt 4 holes tighter. I've known for a long time. I'm his mother, and I will take care of him. She wasn't looking at me, and her voice quavered a little as she talked, holding a crumpled tissue in her hand. A thin gold wedding band looked tight on her finger, and I imagined the young girl she must have been when it was first placed there. Now she was a bit heavy-set. She wore glasses with metal frames, and a simple flowered dress and tan shoes with low heels. The dark wool coat she'd taken off and folded on the back of the chair didn't look warm enough. She brushed at something on her lap and balled the tissue into her fist. She didn't cry. "Mrs. Prava, I think that Marco worries about you nearly as much as you worry about him." She gave a little shake of her head, saying, "Marco. I know we've been over this, and I think everyone wants Marco to be able to come home and stay. It's really the only place for him. I know you're right," I continued, "but there is so much care that he needs. I worry about both of you. I can't send him to a nursing home. I know you can't. We're going to try to make this work. I just feel a bit worried that it will be too hard. I knew that I could bulldoze this situation and send Marco to a nursing home. He might get better professional care there. But really, Marco needed his mother and the love she brought him. She'd end up practically living at the nursing home anyway. I thought again about listening to the distant vibration of the railroad tracks. The only power I had in this situation was to help Marco die peacefully in his home with his mother near him. "Dr. Ball, you are very kind. Mrs. Prava, what you're doing for Marco is so important and so wonderful. Many patients here are alone. Marco is lucky." She hesitated for a moment. "No, Marco is not lucky." God, had I really said that? Marco is lucky? Soiling himself within minutes after having the last dirty diaper changed, racked by cramps and smelling either of feces or that horrible peppermint air freshener that sits like glue in the air, unable to walk or dress or laugh or read or even have a conversation. Lucky? I'm sorry, I said the wrong thing. What I want to say is that Marco has something that so many people with this illness lack. He has someone who loves him. He is here in a great hospital, And I don't think you get better care anywhere else, but the most important thing is your love and your presence. That's what I meant to say. It's all right. I know what you meant. I wish there were more that we could do to help. It will be good to go home. So by 1995, over 500,000 cases and 300,000 deaths from HIV in the U.S. 1995 was also the year that Brad Pitt was the sexiest man alive. The 49ers won the Super Bowl again, but this time Steve Young was the quarterback. The average price of a stamp was 30 cents, and a gallon of gas cost $1.11. This was not my favorite song, but this was the top seller. Okay. 96 was the Vancouver conference, which some of you may recall, and I certainly remember as really the turning point in what was happening with this illness. At the Vancouver conference, the first results from the protease inhibitor studies were presented. And what we started to see in 95 and early 96 and started to have access to these drugs and recognize their efficacy was demonstrated and shown in some of the papers presented there. And for the really first time, we came away from one of these international conferences with the understanding that we finally had a tool that looked like it was really going to work. And this was really the turning point for our ability to take care of our patients, our ability to offer something to intervene in this relentless downward course that we had been facing. Protease inhibitors just work on a different aspect of the replication cycle. More and more of them were developed into the late 90s. Indinavir, which is Crixivan, which is a drug probably most of you've heard of, but then there were several others as well. It was also at this time that we could measure the viral load, so we could actually measure the direct effect of the drugs on the virus, and we also recognized that these drugs had to be given in combinations, which were called cocktails, in something called highly active antiretroviral therapy, or HAART, that in order to overcome the virus's inclination to become resistant to monotherapy. So these are targets of future or further antiretroviral drug development. We have integrase inhibitors, fusion inhibitors, maturation inhibitors, and all these aspects of the viral replication cycle are targets for drug development. This is a slide I took from my infectious diseases chief, Tripp Gulick, just showing that every year we have more and more drugs available to us. So we have now nearly 30 drugs that are used in the treatment of HIV and AIDS. In the early days, specifically, there were a lot of pills to take. When these drugs first came out and the cocktail was recommended, many patients were taking upward of 15, 20, sometimes 30 pills a day. Very regimented courses, multiple directions. Some pills needed food, some needed on an empty stomach, some had to be every 8 hours. Some needed to be, once a day, twice a day, sometimes 3 times a day. It was not easy, but patients who were able to get on these regimens and stick with them did very well. And this is a sort of a CDC, somewhat of an iconic slide, just to show you the change in those rising numbers of deaths and new AIDS cases. The blue line at top being the number of AIDS cases. You see it flatten and start to fall off actually in 92 and 93, and that was a little bit of a false improvement. It was more that they changed the case definition, so they narrowed the case definition, so it looked like there were fewer cases, but it was more just because they had changed the definition. But then this really steep downturn was a direct result of patients having access to and taking these drug combinations, and this was also very apparent in the red line, the number of deaths. Both these lines, though, as you see, did flatten out, and these flatter lines have continued into these days. We still have about between 45 and 50,000 newly diagnosed cases of HIV in this country every year, and about between 18 and 22,000 deaths from AIDS every year. And what that's resulted in, with more new cases being diagnosed than deaths, is the orange line, and that we see the prevalence rates rising, so that there are well over 1 million people in the United States diagnosed with HIV at this point. And this is just a slide to show, in terms of neonatal transmission. One of my good friends is an obstetrician and insisted I include this slide here to show you that we've really had dramatic impact and effect on reducing the cases of newborns being infected. And it's extremely rare that a child is born in this country with HIV. HIV testing is not mandatory, but offering HIV testing to pregnant women is mandatory. So a woman can opt out, but it's rare that a woman does opt out of this kind of thing, because we can really prevent the transmission. So it's occasionally a woman who's had no prenatal care who's HIV infected. And as you see in the number of new babies diagnosed each year has been very small, and it's less than 2%. And that's due to the drug availability, to good counseling, getting women tested, discouraging breastfeeding. So that in 2014, of the 174 children under the age of 13 who were diagnosed with HIV in the U.S., they felt that 127 of them in the entire United States were born with HIV. So this is a great success. Just to show that this is where this slide goes, the timeline just goes out, just to show you those flatter lines, the number of deaths slightly decreasing, slightly, diagnoses also slightly decreasing, but I think actually the number of cases of new diagnoses has been pretty much the same, if not rising slightly, because again of this great prevalence that we have, because patients don't die of AIDS anymore, and it's fairly well recognized that if a patient is newly diagnosed and gets into care, gets onto therapy, their life expectancy is virtually superimposable on someone who's not HIV positive. So we have tremendous success in treating this illness and having patients do well. In the U.S., the distribution between men and women is different than it is in the rest of the world. Worldwide, there are over 32 million people infected with HIV, and that male-female distribution is about 50-50. I think 51% of the cases worldwide are among women. But in the U.S., this is largely driven by MSM, and so the distribution between men and women still remains about less than 30% women. This is a slide just to show you worldwide, again, this 33 million in the bars of number of people living with HIV throughout the world, and to show also that the number of people newly infected has gone down. Treatment programs throughout Africa, which is the place where the vast burden of this illness is located, with national programs, with PEPFAR, with Gates Foundation, Clinton Foundation. All those programs have allowed many hundreds of thousands of people to have access to treatment, so that the number of people newly infected is decreasing. In 1996, Dr. David Ho was named Times Man of the Year for his work. And just to contrast with, just in 2014, the people working with Ebola, these are the few scientists who've ever made the cover of Time magazine as the people of the year, having to do with viral illnesses. And as I mentioned earlier, we are talking about the possibility of curing AIDS. There's studies. Emory just got a big award from the NIH. Temple University has some specific gene mapping techniques that they're working on. So that, and other places around the country are having specific targets to try and get the virus out of its latency period, so that it can have no residual in the body, even in patients who are on medicine. So people really are talking about trying to cure this virus in a way that previously would not have seemed possible. And just to go back to what I said in the beginning, these viral illnesses are not new anymore, and I think that we're going to see, we saw how Zika came around the world in a relatively short amount of time, and we don't know what's going to happen with that this summer and going forward. Ebola, while we were really able to contain it after some real hysteria about it for a brief period of time, Ebola is really a dangerous player, and that's not, completely eradicated. And the bottom line for future programs here in the U.S. is really to get people into care, to get people diagnosed and get them on treatment, because that will reduce their risk of transmission to anyone else. Also, that we know that patients will definitely do better getting on treatment, getting their virus under control for as long as forever, really. And that's the best way to stop this virus. So thank you very much. I'd be happy to answer any questions you have, and sort of a broad story and a broad view. Yes?
I was wondering, at the beginning, when everything was coming to light, what were the diagnostic criteria for AIDS?
Before they, so way in the beginning, they could measure T cell counts. So they were looking at T cell counts, and they looked at lymphadenopathy, and if people were presenting with any kind of opportunistic infection. So way early on, it was a T cell count of under 500, but then they made the parameter under 200 gave you a diagnosis of AIDS. So there was, you have HIV infection, and then AIDS as a progression of HIV infection.
So they did look at CD4 counts back then?
They could get CD4 counts.
Okay, and then they knew to look for that.
And they knew to look for that, because that was one of the first, even in 81, that was something that they noticed. Oh, all these people have very, very low T cell helper cell counts. And so then if you had, then once they could measure the antibody, knew you were HIV positive, if you had HIV positivity but a higher T cell count, then you just had HIV infection, unless you had one of these other conditions, like if you had tuberculosis or widely disseminated shingles, or you had recurrent bacterial pneumonia, that kind of thing, that would be associated with it. If you had that, you would have an AIDS diagnosis, even if your T cells are higher. Yes?
In the late 80s, there was a lot of safe sex education going on that sort of was very explicit and started in the gay community. But it was hard to see from the graphs because the drug treatment sort of kicked in about 7 years later. What evidence is there that kind of safe sex message had an impact?
It's hard to know how much of an impact directly it had. I think it's particularly in the gay community, and just for all of us involved in treating patients with AIDS, we always said just try and use a condom whenever. These days it's more can be potentially a little more challenging because if patients are really well controlled and they take their medications and their viral loads are undetectable, the risk of transmission is negligible. But we still would recommend patients use condoms, use protection. Partly also because there's so much sexually transmitted other illnesses out there. There's so much syphilis and gonorrhea and herpes and the list. But I think just as a method of protection among in the early days before treatment, it's hard to measure how much of an impact. We used to call it safer sex because we knew it wasn't 100%. But it was definitely something that we would always encourage patients to use. Well, thank you very much. If she would be willing to hang around it.